Bismillahirrahmanirrahim. I'd like to thank the organizing committee for inviting me to give this talk, and I thank my professor Dr. Berkoed, and I wish all success to him and our society. My topic today is viral and fungal infections in renal transplant recipients. I've said this topic before and it's continued to be said because this is a very important topic. And the agenda will include general outline, including the risk of post-transplant infection, timeline of infection. Then we'll speak about the viral infections, fungal infections, infection prophylaxis, and then take-home message. Infection is the most important cause of early morbidity and mortality following renal transplantation. Actually, it's a nightmare for transplanters. And that's because of blunted inflammatory responses, which results in diminished symptoms and signs and even radiological findings, such that by the time the patient comes to presentation, it's already too late. And what makes things worse is that the infection, whether it's fever, it does not necessarily indicate an infectious cause. It could be due to acute rejection or drug toxicity, etc. So you have to have a high degree of suspicion, just not to lose your patient, and we always remember that you're running out of time. Infection in the renal transplant recipient can be either one of the common community-acquired bacterial and viral infections, and this differs from the general population in that it's more severe and tends to be polymicrobial, or it could be opportunistic infections, which comes to clinical significance only when the immunity is compromised, and infection can be coming from the recipient or the donor. That's why you have to make sure that they're both free of infection prior to transplantation. And of course, the problem comes with secondary transplantation when the recipient might be having a systemic infection, lyme infections, and the possibility of contamination during organ procurement. Well, the net state of immunosuppression that you just heard does not only depend on the dose, but also on the net state of immunosuppression and whether the patient was receiving other drugs before, chemotherapies or other immunosuppressive drugs, and the host defense deficits engendered by the underlying disease like diabetes or hypogammaglobulinemia, neutropenia, the general health of the patients, malnutrition, the presence of co-modulatory viruses, etc. And the risk of infection does not only depend on the net state of immunosuppression, but actually it's an interplay of those three factors, because also epidemiologic exposure is important, and whether or not the patient is receiving prophylaxis is important. So you say that the patient is has a high risk if, for instance, he's receiving induction therapy or he had a high instance of high risk of rejection. Okay, if there's a technical cause, like for instance anastomotic bleeding or return to OR, or if the patient develops delayed graft function, and he's said to be of lower risk if he is having none of those, and if the patient is receiving proper prophylaxis, antimicrobial prophylaxis. Now, this is the timeline of infections that you're all acquainted with, and just to remind you that during the first months of post-transplant, you usually get the normal nosocomial infections that occur with any operation, like the wound infections, urinary infections, pneumonia, and vascular access and candida infections. You can have early activation of herpes simplex virus, and also hepatitis B and C virus may be activated early. And so you don't usually get opportunistic infections during the first month. From the first to the second month, the patient is receiving a big dose of immunosuppressive medications, and this is the time where you get opportunistic infections like viral infections, protozoal infections, and also fungal infections. Now, after the 6 months, the patient is receiving immunosuppressive dose that at the level of maintenance level, and the effect of induction therapy is dissipating. So he starts back to get, in 80% of the cases, to get the community-acquired bacterial and viral infections, but there remains a percentage of patients, about 10 to 20%, that continue to develop opportunistic infections, and these actually are the patients that are doing well and requiring a big doses of immunosuppressive medications and, of course, prolonged antimicrobial prophylaxis. And also, you start to get the sequelae of infections. You get peritonitis, for instance, with cytomegalovirus. You get malignancy, like you just heard about the post-transplant proliferative disorders with the Epstein-Barr virus. You get squamous cell carcinoma with papillomavirus, you get hepatoma with hepatitis viruses, etc. Now, so this is the timeline that has been going on since a very long time, 1998, but it does not remain that simple. Life is not getting complex all the time. So what's happening now is that with more and more patients coming already immunosuppressed to transplantation, like those patients with glomerulonephritis and HIV patients, so you start to get opportunistic infections early on. Also, the use of prophylactic antiviral, you can have a shift to the right of the occurrence of viral infections, so you can get cytomegalovirus occurring after 6 months. And with the use of potent immunosuppressive drugs, you start to get other viruses like the BK virus and the parvovirus and the West Nile virus. And with the use of plasma exchange and bortezomib and splenectomy, you remove antibodies and you can get more infection of the encapsulated organism. What's also happening now is you get more, during the first month, you get more of antimicrobial resistant bacteria like the MRSA and vancomycin resistant Enterococci and the non-albicans candidal infections. And also, donor-derived unusual infections are an emerging issue, like, for instance, infection with lymphocytic cholangitis, rabies, and West Nile viruses. When you come now to the timeline between 1 and 6 months, you divide infections depending on whether or not the patient is receiving prophylactic treatment. So those with pneumocystis and cytomegalovirus prophylaxis tend to develop polyomavirus and hepatitis C virus more, and those who are not receiving prophylaxis are likely to get pneumocystis and herpes virus. These are the opportunistic infections that we're talking about, and we are going to concentrate now on the viral and fungal infections, and I'm going to linger on the more important common infections, and I will quickly by the less common infections. So speaking of viral infections, of course you all know the human herpes viruses family, famous family, and we'll start with the cytomegalovirus because it is the single most important pathogen in organ transplantation. It starts usually to appear after the first month post-transplant, and when the donor is positive, you have a risk of infection of 50 to 75%. When the recipient is positive, whether or not the donor is positive, the risk of infection is 25 to 40%, and when both are negative, the risk of infection is less than 50%. When there is infection, rejection, or cytotoxic drugs, you get the release of cytokines that converts a latent cytomegalovirus into an active one, and you start to get viral syndromes with 2-like and 1 nucleolus-like syndromes. You get affection of the graft and other organs like nephritis, hepatitis, carditis, etc. And you have an indirect effect due to the release by the cytomegalovirus itself of cytokines, resulting in abrupt injury and rejection, in each of which could be either acute or chronic. And you can have systemic immunosuppression that you get opportunistic infection. It's very likely that you don't get cytomegalovirus alone. It's usually associated with other infections. So it is stimulated by cytokines that itself produces cytokines. And also you get a 10% increased incidence of Epstein-Barr virus-associated lymphomas. It is said to increase the risk of post-transplant diabetes mellitus and to produce an accelerated course of hepatitis C virus. And this is how it appears in the biopsy specimens. You get inflammatory reaction with these viral inclusions that, if had it not been for the viral inclusions, it could be confused with acute rejection. Graft survival is definitely better when cytomegalovirus is not there. And how to diagnose cytomegalovirus? Well, the best thing is to detect the viral antigens, the PP65, or to have a positive PCR. You can get also positive blood culture, but of course this is going to take longer. And as you have seen, CMV and biopsy specimens. And please mind you not to depend on serological tests because they are of less diagnostic value. The patient may not produce antibodies or may have a delayed production of antibodies, and also you can have positive antibodies with false positive antibodies. How to treat cytomegalovirus? We have prophylactic treatment, that's to say before the patient develops infection, and you have the preemptive treatment after infection occurs but before the clinical disease occurs, and you have the therapeutic treatment when it is disease. So for prophylaxis and for the high-risk patients, you give 6 months for the donor-positive patients, and you give 3 months for the recipient positive patients. ganciclovir 5 milligrams per kg once daily, or valganciclovir 900 milligrams once daily. And you can also use for prophylaxis acyclovir and valganciclovir. For the preemptive, you do serial monitoring of the antigens or the PCR, and at a certain cutoff, you start to start treatment before the disease occurs, and this prevents the indiscriminate use of antivirals and the occurrence of resistant strains. And here you can see that there is an improved renal allograft survival with anti-cytomegalovirus prophylaxis. And for treatment, when there is an established clinical infection, so the first thing to do is to decrease the immunosuppression, and you double the dose that we have mentioned. So you use ganciclovir intravenously, 5 milligrams per kg twice, not once, and the valganciclovir is given in a dose of 900 milligrams twice, and you have to document clearance of the virus before stopping the drug or changing ganciclovir to the oral formulations to prevent relapse and limit resistance. We can also use cytomegalovirus hyperimmunoglobulins for severe or relapsing cases, and you can use phosphorinate and tenofovir, which are toxic for resistant cases. Now, for the rest of the herpes virus, you have the type herpes simplex virus 1. You get the Vialis herpes, and usually it does not show. It's not a great problem with the prophylaxis, but it can appear later and may require prolonged prophylaxis. And you can also get pneumonia, and you can get systemic infections. And you have the herpes simplex type 2, the genital herpes. You have the varicella zoster herpes producing dermatitis, but can also produce systemic infection. If done by virus, you already have about it. And cytomegalovirus, we already covered it. Human herpes 6 and 7 producing roseola, and type 8 producing sarcoma. And now we come to the next important one, which is the polyomavirus, which is subgroups. So the most important that we care about is the VK virus, because it occurs in transplant patients as early as 8 weeks post-transplant. And it can cause ureteric stenosis, hemorrhagic cystitis, and interstitial nephritis. You start first, you go from below upwards, you can get decoy cells, which start first a few cells and then become abundant, and you get tubular injury. And this particularly happens more commonly with a combination of tacrolimus MMF, and then you get a VK viremia. And if you look here, you can see that the commonest combination to occur with is the tacrolimus MMF, and the least common to occur with is the cyclosporin MMF again. So it's not the MMF apparently. And this is what it does in the graft biopsy, where you get heterogeneous inflammatory reactions with lymphocytes, macrophages, plasma cells, and with the hallmark is the presence of viral inclusions, internuclear inclusions that are specifically present in the proximal tubules. And here you can see that the graft survival is definitely better when the VK virus is not there. And to diagnose, we just mentioned pathology. You can also do monoclonal antibody staining, and you can have electron microscopy showing crystalline arrays. PCR in the blood is the preferred test with a sensitivity of 100% and a positive predictive value of 85%. PCR in urine appears early on. It can be used to follow up the diagnosed cases. And the core cells are characteristic, but they're not pathognomonic. Sensitivity is 100% and a positive predictive value of 27%. So if they're not there, it's good. But if they are there, it does not necessarily mean that the patient has the disease. And to treat polyomavirus, most important thing is to reduce immunosuppressive, and some patients do improve after that. And then you have a whole list of drugs. I think the safest of them is the quinolones, that you can try that. And now the HC virus, hepatitis C virus can produce 3 forms of injury in the renal allografts. You can have acute and chronic glomerulopathy, and you can have immune complex-mediated glomerulopathy, membranous proliferative and membranous, and you can have thrombotic microangiopathy related to formation of antiphospholipid antibodies. Now, mind you, the pathology of renal thrombotic microangiopathy mimics a huge hemoral rejection and is sometimes mistaken for cyclosporin toxicity. And we have also 2 more viruses, the papillomavirus that is associated with squamous cell carcinoma of the skin and the cervix, and you have the parvovirus that can produce aplastic anemia, can contribute to rejection, and can cause thrombotic microangiopathy, and it has an incidence of 3% in transplant rejection patients. Now we come to viral infections, and the commonest is the candidiasis, which is not really much problem with early prophylaxis, but without prophylaxis it affects as many as 10 to 30%. And it can also produce a systemic affection. And the second common is Aspergillus, and this can affect the lungs. You can do a bronchoalveolar lavage, and by needle aspiration cytology will aid in prompt diagnosis by finding fungal bowls and branching hyphae. And it also affects the brain, producing infarctions and hemorrhages. Cryptococcal infections have an incidence of 2.8% with a death rate of 42%. It can affect the central nervous system, producing meningitis in the majority of cases, pulmonary infection of unilateral nodular or cavitary infiltrates, and soft tissue and osteoarticular tissue. It is diagnosed by blood and CSF cultures, serum and CSF cryptococcal antigens, and mind you, leukocytosis is absent. And also, I'd like to draw your attention to the fact that tacrolimus is associated with a less likely incidence to develop CNS involvement because it is antifungal and because it crosses the blood-brain barrier. Now, this is summarizes the treatment of fungal infections. Of course, you have the mucocutaneous candidiasis, you use the oral statin and the definitive treatment of fluconazole. Then you have the preemptive treatment can be given for candidiuria, aspergillus, and cryptococcus. You can use the fluconazole. Now, for the definitive treatment, things have been changing lately. You use fluconazole for the mucocutaneous candidiasis. For candidiuria, you use fluconazole and amphotericin B, the oxalate. You don't use the liposomal force, it does not reach the kidney properly. And for invasive candidiasis, you also get, in addition, the voriconazole and the echinocandins. And for aspergillus, you use the voriconazole and the cascopamide. And for mucormycosis, you can use the amphotericin B, liposomal form, and also the posaconazole. And for cryptococcus, you use amphotericin plus flucytosine, and then you shift to fluconazole. I just want to draw your attention here that non-candidate, non-alpha candida of different types, and you have to know exactly the sensitivity because it differs from one species to another, so this is very important that you stress on. So now you see that our patients, they tolerate infection poorly, and the cornerstone will be to do prophylactic treatment, and this starts with the vaccination. So you have to finish hepatitis B virus high-dose vaccines prior to transplantation and preferably prior to dialysis, and you should give hepatitis A virus vaccine if the condition is endemic, pneumococcal vaccinations, influenza given yearly, Haemophilus and meningococcal if the patient has asplenia, and please notice that you avoid receiving live attenuated vaccines. And for infection prophylaxis, you give antibacterial, you give prophylaxis for pneumocystis pneumonia, you use salpamethixazole, which is also going to help against urinary tract infections, listeria, nocardia, toxoplasma, and legionella. You use antiviral treatment as cyclovir and again cyclovir, and you give interferon pre-transplant for hepatitis C virus, but of course we can treat it now post-transplant. And for antifungal, like we mentioned, we can give cystatin and we can give fluconazole 100 milligrams every week. And for antituberculous, you give INH 300 milligrams per day for those who have a history of TB or coming from an endemic area. And please notice that there are drugs that would increase the cyclosporin K of sirolimus, like the azoles, like erythromycin and clarithromycin, but not azithromycin. And other drugs that we've mentioned decrease the cyclosporin K of sirolimus, like the rifampicin and the INH. So in conclusion, infection following transplantation is largely dependent on the net state of immunosuppression. Opportunistic infection should be sought for and suspected early in transplant patients. Rapid institution of treatment based on correct diagnosis is crucial for good clinical outcome. Be aggressive. Imaging or biopsy must be performed in a timely manner before the patient's illness progresses to a point where such procedures can no longer be done. Vaccination and prophylaxis can prevent many infectious complications, and whenever you face acute rejection, please consider an underlying viral infection. Antibiotic prophylaxis needs to be resumed following treatment of rejection, and prophylactic antivirals should be resumed for a minimum of 6 weeks after treatment of rejection. And we need to have biomarkers for the state of immunosuppression. And thank you very much.
أول بالمفروض thank you very much for your elegant presentation. شيء ورائع. What is the value of screening and monitoring for the viral titers مش بس سي بي والبوليوما الهربس فيروس كاتيجوريز كلها من تايب 1 لغايه 8 do we benefit really from monitoring and screening initially pre-transplantation and the cost benefit of this?
I don't think we do preemptive treatment for that. We usually give prophylactic treatment early on, and then you might get the virus.
I'm asking about the screening initially, screening and monitoring.
Screening before transplantation, sorry. هي برضه تعتمد على المكان والprevalence of infection اللي موجود. If you are in a place where you have endemic affection of herpes, other types of viral infection, then you do it, but you don't have to do everything. You don't have to do everything, of course. So here we use عادة احنا بنعمل الساتوميجالوفيروس
في environmental areas مثلا زي استراليا عندهم very high incidence of herpes and they have a usual screening for the herpes type 6 and 8 and so on. But we don't do this in Egypt. Do we have any impact of not screening on our outcome?
I don't know.
Probably we can take an experience also from the so do you have any experience of these viral infections not screening them?
I think it is good idea to screen patients since I think we observed that our Kaposi cases usually come in crops. This may give a clue that it is related to a sort of infection. We observed this very long time before knowing this information that it have relation with herpes 8. But of course screening and prophylaxis is important, yes.
I cannot answer because احنا ما عملناش دراسة عشان جربنا ان احنا خدنا ناس وعملناهم screening وناس تانيين ما عملناهمش screening and we say what happens. But maybe.
طب أقول كلمة يا دكتورة يعني احنا عندنا هنا الانسيدنس اوف prevalence of malignant skin tumor قليل مش كتير. يعني انا مثلا بتابع حوالي 1500 عيان، يمكن كابوس ساركوما حصلت في 7 مثلا. والاذر نان كابوسي سكين تيومر اكستريملي رير، بس هي اقوى في استراليا والحته دي عشان هم هوايت والسن اكسبوجر عالي. it may be worth it لكن هنا لا.
هو الكابوسي بالذات is relatively common. اعتقد من اكثر حتت في العالم الكابوسي هي الميديترينيان والعرب والجيوش، واحنا اعتقد عندنا عدد حالات كتير، يعني مش عارف الزملاء الموجودين اتليست ممكن اكثر من 20 حاله يعني.
في كام؟
Well, it's the commonest that we see.
في كام دول؟ في كام
انا مش عارف الارقام حاليا بس always you have case of كابوسي يعني but عموما information is not Mediterranean Jewish Arab are highest incidence of كابوسي غير السكويبر سيل كارسينوما.
طب برضه يعني treatment of كابوسي is more or less easy. يعني حتى لو حصلت simply reduction of immune suppression will cure most of it. I think it's not so big.
هي كابوسي is يعني يمكن معظم العيانين بتاعنا we succeeded to induce regression of tumor. even في كان عندنا حاله من قريب كان مش سكين كابوسي بس، لا كان عندنا بالمونري وهيباتيك وفاكر كان جاب هيماتيمسيس فكان في جاستريك وكان شكل عام كده ضايع. we could gradual regression decrease يعني المشكله في اول حاجه انا فاكر قابلناها يمكن من اكثر من 20 سنه، اول عام نشوفه كابوسي اترعبنا وقرينا نيتريشن قالينها قال لك وقف الميون سبريشن حط على دايلسيس. انا فاكر الكلام القديم ده، انما ايفن في فيرست ايرلي كيسز احنا we didn't adopt this policy. We decrease the immune suppression gradually and the tumor regressed.
وريبليس السايكل مثلا بحاجه زي الهيماتوز ولا حاجه
حديثا
طول مروان هذا كمان.
So cost benefit should be considered actually.
طول مروان.
I'm very delighted for your question. We do screening only for our cadaveric patients.
for allocation. نعمل احنا كل الفيرال pathogens. And this is the reason, so when you allocate your organ for a patient, you go for the matching. If it's positive, you do not give it for a يعني scoring system بيخليك تروح على patient that is positive rather than do it for a negative patient, and you try to give the negative patient for a negative patient, not for a positive. The second part, which is very important, is about the بلبنان بال 2012 مرت علينا فقط 11 حالة تي بي. بال 2014 450 حالة. So يعني if you ما كناش نعملها اليوم اضطرينا انه نعملها. يعني the prevalence of the viral infection أو bacterial infection هو اللي عم يخلينا نعمل سكرين مش just routine.
And what about your live donors?
Live donors, we do screen them. We do screen them but not for the matching. يعني they do the donor and the recipient, but this is
I mean for viral.
for viral.
لا يعني does it include زي ما بنقول
بس ما بنشوفش يعني
papilloma.
but we have we do Epstein virus, we do hepatitis, we do the
Hepatitis, yes.
HIV, we do the herpes, okay, and we do now we do the TB. We were not doing the TB before. Now we are obliged to do it. But the thing, what is everybody is saying, even us, we don't know the impact of this screening on the graft survival after 5 years or 6. We do not have that.
كنت عايز اسال سؤال بالنسبه للتشينج بقى من الفيروس والبكتيريا للفنجل وبالنسبه لنا هاو فريكوينت واف ات از ريزيستنت هل احنا بنستوب برضه؟
It's always a balance between,
Immunosuppressive.
yes, of course, it's always a balance between the patient's life and how far is the infection going on. So if it's something mild and it's not invasive, if it's something invasive, you have to stop.